a WikiVidi documentaries production. Don't forget to like and subscribe. Enjoy. Heroin. Heroin, also known as diamorphine among other names, is an opioid most commonly used as a recreational drug for its euphoric effects. Medically, it is used in several countries to relieve pain or in opioid replacement therapy. Heroin is typically injected, usually into a vein. However, it can also be smoked, snorted or inhaled. The onset of effects is usually rapid and lasts for a few hours. Common side effects include respiratory depression, dry mouth, drowsiness, impaired mental function, and addiction. Other side effects can include abscesses, infected heart valves, blood-borne infections, constipation, and pneumonia. After a history of long-term use, withdrawal symptoms can begin within hours of last use. When given by injection into a vein, heroin has 2 to 3 times the effect as a similar dose of morphine. It typically comes as a white or brown powder. Treatment of heroin addiction often includes behavioral therapy and medications. Medications can include buprenorphine, methadone, or naltrexone. A heroin overdose may be treated with naloxone. An estimated 17 million people as of 2015 use opiates such as heroin, which together with opioids resulted in 122,000 deaths. The total number of opiate users has increased from 1998 to 2007, after which it has remained more or less stable. In the United States, about 1.6% of people have used heroin at some point in time. When people die from overdosing on a drug, the drug is usually an opioid. Heroin was first made by C.R. Alderite in 1874 from morphine, a natural product of the opium poppy. Internationally, heroin is controlled under Schedules 1 and 4 of the Single Convention on Narcotic Drugs. It is generally illegal to make, possess, or sell heroin without a license. In 2015, Afghanistan produced about 66% of the world's opium. Heroin, which is illegally sold, is sometimes mixed with other substances such as sugar, starch, quinine, or strychnine. Recreational. The original trade name of heroin is typically used in non-medical settings. It is used as a recreational drug for the euphoria it induces. Anthropologist Michael Agar once described heroin as the perfect whatever drug. Tolerance develops quickly, and increased doses are needed in order to achieve the same effects. Its popularity with recreational drug users, compared to morphine, reportedly stems from its perceived different effects. Short-term addiction studies by the same researchers demonstrated that tolerance developed at a similar rate to both heroin and morphine, when compared to the opioids hydromorphone, fentanyl, oxycodone, and pethidine. Former addicts showed a strong preference for heroin and morphine, suggesting that heroin and morphine are particularly susceptible to abuse and addiction. Morphine and heroin were also much more likely to produce euphoria and other positive subjective effects when compared to these other opioids. Medical uses. In the United States, heroin is not accepted as medically useful. Under the generic name diamorphine, heroin is prescribed as a strong pain medication in the United Kingdom, where it is administered via subcutaneous, intramuscular, intrathecal or intravenously. It may be prescribed for the treatment of acute pain, such as in severe physical trauma, myocardial infarction, post-surgical pain and chronic pain, including end-stage terminal illnesses. In other countries, it is more common to use morphine or other strong opioids in these situations. In 2004, the National Institute for Health and Clinical Excellence produced guidance on the management of caesarean section, which recommended the use of intrathecal or epidural diamorphine for post-operative pain relief. Diamorphine continues to be widely used in palliative care in the UK, where it is commonly given by the subcutaneous route, often via a syringe driver, if patients cannot easily swallow morphine solution. The advantage of diamorphine over morphine is that diamorphine is more fat-soluble and therefore more potent by injection, so smaller doses of it are needed for the same effect on pain. Both of these factors are advantageous of giving high doses of opioids via the subcutaneous route, which is often necessary in palliative care. Maintenance therapy. A number of European countries prescribe heroin for treatment of heroin addiction. Diamorphine may be used as a maintenance drug to assist the treatment of opiate addiction. Normally in long-term chronic intravenous heroin users, it is only prescribed following exhaustive efforts at treatment via other means. It is sometimes thought that heroin users can walk into a clinic and walk out with a prescription, but the process takes many weeks before a prescription for diamorphine is issued. Though this is somewhat controversial among proponents of a zero-tolerance drug policy, it is proven superior to methadone in improving the social and health situations of addicts. The UK Department of Health's Rolleston Committee report in 1926 established the British approach to diamorphine prescription to users, which was maintained for the next 40 years. Dealers were prosecuted, but doctors could prescribe diamorphine to users when withdrawing. In 1964, the Brain Committee recommended that only selected approved doctors working at approved specialized centers be allowed to prescribe diamorphine and benzomethylquinine to users. The law was made more restrictive in 1968. Beginning in the 1970s, the emphasis shifted to abstinence and the use of methadone. Currently only a small number of users in the UK are prescribed diamorphine. In 1994, Switzerland began a trial diamorphine maintenance program for users that had failed multiple withdrawal programs. The aim of this program was to maintain the health of the user by avoiding medical problems stemming from the illicit use of diamorphine. The first trial in 1994 involved 340 users, although enrollment was later expanded to 1,000, based on the apparent success of the program. The trials proved diamorphine maintenance to be superior to other forms of treatment in improving the social and health situation for this group of patients. It has also been shown to save money, despite high treatment expenses, as it significantly reduces costs incurred by trials, incarceration, health interventions, and delinquency. Patients appear twice daily at a treatment center, where they inject their dose of diamorphine under the supervision of medical staff. They are required to contribute about 450 Swiss francs per month to the treatment costs. A national referendum in November 2008 showed 68% of voters supported the plan, introducing diamorphine prescription into federal law. The previous trials were based on time-limited executive ordinances. The success of the Swiss trials led German, Dutch, and Canadian cities to try out their own diamorphine prescription programs. Some Australian cities have instituted legal diamorphine supervised injecting centers, in line with other wider harm minimization programs, since January 2009. Denmark has prescribed diamorphine to a few addicts that have tried methadone and Subutex without success. Beginning in February 2010, addicts in Copenhagen and Odense became eligible to receive free diamorphine. Later in 2010, other cities including Aarhus and Esbjerg joined the scheme. It was supposed that around 230 addicts would be able to receive free diamorphine. However, Danish addicts would only be able to inject heroin according to the policy set by Danish National Board of Health. Of the estimated 1,500 drug users who did not benefit from the then-current oral substitution treatment, approximately 900 would not be in the target group for treatment with injectable diamorphine, either because of massive multiple drug abuse of non-opioids, or not wanting treatment with injectable diamorphine. In July 2009, the German Bundestag passed a law allowing diamorphine prescription as a standard treatment for addicts. A large-scale trial of diamorphine prescription had been authorized in the country in 2002. On August 26, 2016, Health Canada issued regulations amending prior regulations it had issued under the Controlled Drugs and Substances Act. The New Classes of Practitioners Regulations, the Narcotic Control Regulations, and the Food and Drug Regulations, to allow doctors to prescribe diamorphine to people who have a severe opioid addiction who have not responded to other treatments. The prescription heroin can be accessed by doctors through Health Canada's Special Access Program for emergency access to drugs for patients with serious or life-threatening conditions when conventional treatments have failed, are unsuitable, or are unavailable. Routes of administration. The onset of heroin's effects depends upon the route of administration. Studies have shown that the subjective pleasure of drug use is proportional to the rate at which the blood level of the drug increases. Intravenous injection is the fastest route of drug administration, causing blood concentrations to rise the most quickly, followed by smoking, suppository, insufflation, and ingestion. Ingestion does not produce a rush as forerunner to the high experienced with the use of heroin, which is most pronounced with intravenous use. While the onset of the rush induced by injection can occur in as little as a few seconds, the oral route of administration requires approximately half an hour before the high sets in. Thus, with both higher the dosage of heroin used and faster the route of administration used, the higher potential risk for psychological addiction. Large doses of heroin can cause fatal respiratory depression, and the drug has been used for suicide or as a murder weapon. The serial killer Harold Shipman used diamorphine on his victims, and the subsequent Shipman inquiry led to a tightening of the regulations surrounding the storage, prescribing and destruction of controlled drugs in the UK. John Bodkin Adams is also known to have used heroin as a murder weapon. Because significant tolerance to respiratory depression develops quickly with continued use and is lost just as quickly during withdrawal, it is often difficult to determine whether a heroin lethal overdose was accidental, suicide or homicide. Examples include the overdose deaths of Sid Vicious, Janis Joplin, Tim Buckley, Hillel Slovak, Lane Staley, Bradley Nowell, Ted Binion, and River Phoenix. Chronic use of heroin and other opioids has been shown to be a potential cause of hyponatremia, resultant because of excess vasopressin secretion. By mouth. Use of heroin by mouth is less common than other methods of administration, mainly because there is little to no rush, and the effects are less potent. Heroin is entirely converted to morphine by means of first-pass metabolism, resulting in deacetylation when ingested. Heroin's oral bioavailability is both dose-dependent and significantly higher than oral use of morphine itself, reaching up to 64.2% for high doses and 45.6% for low doses. Opiate-naive users showed far less absorption of the drug at low doses, having bioavailabilities of only up to 22.9%. The maximum plasma concentration of morphine following oral administration of heroin was around twice as much as that of oral morphine. Injection. Injection, also known as slamming, banging, shooting up, digging, or mainlining, is a popular method which carries relatively greater risks than other methods of administration. Heroin base, when prepared for injection, will only dissolve in water when mixed with an acid and heated. Heroin in the East Coast United States is most commonly found in the hydrochloride salt form, requiring just water to dissolve. Users tend to initially inject in the easily accessible arm veins, but as these veins collapse over time, users resort to more dangerous areas of the body, such as the femoral vein in the groin. Users who have used this route of administration often develop a deep vein thrombosis. Intravenous users can use a various single-dose range using a hypodermic needle. The dose of heroin used for recreational purposes is dependent on the frequency and level of use. Thus, a first-time user may use between 5 and 20 milligrams, while an established addict may require several hundred mg per day. As with the injection of any drug, if a group of users share a common needle without sterilization procedures, blood-borne diseases, such as HIV/AIDS or hepatitis, can be transmitted. The use of a common dispenser for water for the use in the preparation of the injection, as well as the sharing of spoons and/or filters, can also cause the spread of blood-borne diseases. Many countries now supply small sterile spoons and filters for single use in order to prevent the spread of disease. Smoking. Smoking heroin refers to vaporizing it to inhale the resulting fumes, rather than burning and inhaling the smoke. It is commonly smoked in glass pipes made from glass-blown Pyrex tubes and light bulbs. Heroin may be smoked from aluminium foil, which is heated by an underneath flame, with the resulting smoke inhaled through a tube of rolled-up foil, a method also known as chasing the dragon. Insufflation. Another popular route to intake heroin is insufflation, where a user crushes the heroin into a fine powder and then gently inhales it into the nose. Where heroin is absorbed through the soft tissue in the mucous membrane of the sinus cavity and straight into the bloodstream. This method of administration redirects first-pass metabolism, with a quicker onset and higher bioavailability than oral administration, though the duration of action is shortened. This method is sometimes preferred by users who do not want to prepare and administer heroin for injection or smoking, but still experience a fast onset. Snorting heroin becomes an often unwanted route. Once a user begins to inject the drug, the user may still get high on the drug from snorting, and experience a nod, but will not get a rush. A rush is caused by a large amount of heroin entering the body at once. When the drug is taken in through the nose, the user does not get the rush, because the drug is absorbed slowly rather than instantly. Suppository. Little research has been focused on the suppository or pessary methods of administration, also known as plugging. These methods of administration are commonly carried out using an oral syringe. Heroin can be dissolved and withdrawn into an oral syringe, which may then be lubricated and inserted into the anus or vagina before the plunger is pushed. The rectum or the vaginal canal is where the majority of the drug would likely be taken up, through the membranes lining their walls. Short-term effects. Users report an intense rush, an acute transcendent state of euphoria, which occurs while diamorphine is being metabolized into 6-monoacetylmorphine and morphine in the brain. Some believe that heroin produces more euphoria than other opioids. One possible explanation is the presence of 6-monoacetylmorphine, a metabolite unique to heroin, although a more likely explanation is the rapidity of onset. While other opioids of recreational use produce only morphine, heroin also leaves 6-MAM, also a psychoactive metabolite. However, this perception is not supported by the results of clinical studies comparing the physiological and subjective effects of injected heroin and morphine in individuals formerly addicted to opioids. These subjects showed no preference for one drug over the other. Equipotent injected doses had comparable action courses, with no difference in subjects' self-rated feelings of euphoria, ambition, nervousness, relaxation, drowsiness, or sleepiness. The rush is usually accompanied by a warm flushing of the skin, dry mouth, and a heavy feeling in the extremities. Nausea, vomiting, and severe itching may also occur. After the initial effects, users usually will be drowsy for several hours. Mental function is clouded, heart function slows, and breathing is also severely slowed, sometimes enough to be life-threatening. Slowed breathing can also lead to coma and permanent brain damage. Long-term effects. Repeated heroin use changes the physical structure and physiology of the brain, creating long-term imbalances in neuronal and hormonal systems that are not easily reversed. Studies have shown some deterioration of the brain's white matter due to heroin use, which may affect decision-making abilities, the ability to regulate behavior, and responses to stressful situations. Heroin also produces profound degrees of tolerance and physical dependence. Tolerance occurs when more and more of the drug is required to achieve the same effects. With physical dependence, the body adapts to the presence of the drug, and withdrawal symptoms occur if use is reduced abruptly. Brought to you by WikiVidi documentaries. Would you like to know more?